Ladies and gentlemen, dear colleagues, dear friends, let me all welcome you to the WHO ILAE IBE joint webinar on optimizing care. Epilepsy and pregnancy in women and girls is the topic for today's seminar. And it's quite an important webinar, I would say, for several reasons. As you can imagine, the effect of anti-seizure medicines on the women and on unborn child are of enormous importance. It's not only the unwanted effects, but it's also the wanted effects. So we have to look at seizure control on one side and on the unwanted effects on women and on the unborn child in women. So specifically valproic acid, but also other anti-seizure medicines are problematic in this aspect. What I have to say at this moment, and the occasion which we took for organizing this webinar, is a new guideline to which we come a little bit later. When we look now for the overall risks of valproic acid, there's a 10% risk of fetal malformation and around 30 to 40% risk of neurodevelopmental difficulties in children born to women taking valproic acid during pregnancy. But on the other hand, valproic acid is still one of the most often prescribed anti-seizure medicines, and in some epilepsy syndromes, it is one of the most effective drugs we have. So there is a true dilemma, and therefore it's important to recognize these risks and to have guidelines for informed decision-making and careful management in this critical population, more than half of the world population. And this webinar explores the best practices and challenges for women and girls with epilepsy, with a focus on mitigating these risks. Well, I have to say that you are not able to speak directly to this webinar, but there is a chat function, and it's very important that you all at home come up with the critical questions with the problems. But what we cannot do is answer individual treatment decisions. But whatever you want to know, we are here to answer. So the goals of the webinar is to inform about the updated MHGAP guidelines. MHGAP means Mental Health Gap Action Program. But what we are talking about is not only mental, it is brain disorder, and these are the human beings which have to live with potential disabilities or other problems which you have after a pregnancy with valproic acid. So this is one point. The other point is to raise awareness among stakeholders about the relative risks of prescribing in women and girls, and provide the guidance about the treatment options which we have currently available, and to highlight the importance of a shared decision-making and individualized care when managing epilepsy in women planning pregnancy or already pregnant, because this is also an issue that very often there was no pre-pregnancy counseling and the women come and say that they are pregnant. But what is important is always to consider both sides: seizure control, possible impact of seizures on the unborn and on the women, and the effects of the anti-seizure medicine on the unborn child. So we are very proud that we have a group of outstanding experts which are going to present first the overview about the WHO MHGAP guidelines, and then we have a panel discussion from people all over the world with a long-standing experience in treating, counseling from different regions. And afterwards we have a Q&A session, so we are very happy to take all the questions at the Q&A session. Please put it in the chat whenever you have time, and be prepared for the closing remarks. And I'm looking forward to the discussion there. So I'm going to introduce the speakers to you now. So, the conflict of interest, that's important. You see the conflict of interest here, which are potentially important. Next slide, please. And what is important for us, that the webinar is not industry sponsored, and it's the intellectual property of the speakers of WHO, ILAE, and IBE. So we have composed a list of outstanding speakers, and I'm very happy and proud to have as the first speaker from the WHO, Nerja Chaudhary, Technical Officer in the Department of Mental Health, Brain Health, and Substance Use, which is together now in the WHO headquarters in Geneva, Switzerland. Noha Isa, Technical Officer in Pharmacovigilance Team, also at the WHO headquarters, Geneva, Switzerland. And then Professor Gus Baker, he's Professor Emeritus of Clinical Neuropsychology, and he published a lot of papers in epilepsy field, in neurodevelopmental diseases, disorder, and on quality of life. From Liverpool, UK, and he's currently Secretary General for the International Bureau of Epilepsy. Dr. Paige Pennell, she's an outstanding expert in women of childbearing potential pregnancy. She's an adult neurologist and an epileptologist. She chairs the Department of Neurology for UPMC and the University of Pittsburgh School of Medicine in Pennsylvania. And she's currently the chair of the ILAE Task Force on Women with Epilepsy. Dr. Melody Asukile, she's an adult neurologist and epileptologist from the University Teaching Hospital, Lusaka, Zambia. And she is the chapter president of the Zambia ILAE chapter. And she will provide insight into the challenges of managing women and girls considering pregnancy and discussing good practice in resource low settings. The next speaker will be Dr. Richard Hill. He's a pharmacovigilance expert, and he was a senior medical officer in the clinical and safety monitoring of the International Regulatory Branch at the Therapeutic Goods Administration in Australia. He's recently retired, but he's still very active in the WHO Advisory Committee on Safety of Medical Products, and he will discuss the regulatory frameworks for valproic acid and the strategies we have for safe prescribing. And last but not least is Professor Farhana Diwan. She's professor and head of the Department of Obstetrics and Gynecology at Insidha Medical College and Hospital in Dhaka, Bangladesh, and she's president of the OGSB and secretary general of the SAFOG. So she will address questions regarding policy interventions, including the implementation of guidelines and the coordination of efforts across healthcare sectors to ensure appropriate care. So you see, we have a multi-professional, interdisciplinary, and global panel here, and I'm very much looking forward to the speakers. And I hand over now to WHO MHGAP guideline presentation of Nerja Chaudhary and Noha Isa.
Thank you very much, Eugene, and it's great to see everyone on this in this webinar, and we're very happy to be talking about this important subject today. I'll begin the presentation from the WHO's guidelines point of view, and then hand over to Noha to take you through pharmacovigilance aspects. The next slide, thank you. So MHGAP has been around for a long time now, in fact, more than 15 years. The program was established in 2008 to think about how we can scale up care for mental, neurological, and substance use conditions, involving non-specialist healthcare providers in providing care for these conditions. The guidelines, which are based on the latest evidence, have been regularly updated. And in fact, last year, we published the 2023 update of the MHCAP guidelines. And this brought together what we know and what is the latest evidence on the management of these priority conditions. And epilepsy is one of the conditions that is a focus of MHCAP. Now, in order to help countries and support countries in implementation of these guidelines, we have a range of derivative products, including the MHCAP Intervention Guide and the Humanitarian Intervention Guide. These guides basically provide algorithms that healthcare providers can use in order to assess and manage a range of conditions, including epilepsy. There is also the training manuals, which are for the training of trainers as well as for training of healthcare providers. There is the MHCAP operations manual, which tells a program manager or a person working in the districts about how they can integrate care for mental, neurological, and substance use conditions within their care programs, within primary health. And we have the MHCAP Community Toolkit, which is for community providers and how they can provide care to this population. The next slide. Excuse me. So here is the aim of the MHCAP guidelines. Like I said, to provide up-to-date WHO guidance to facilitate the delivery of mental, neurological, and substance use interventions by non-specialists working in low and middle-income countries. It's also relevant, of course, to people working in high-income countries. The latest guidelines and the latest update includes 90 existing recommendations from the previous 2015 guidelines that are still valid. But in addition, there are 18 new recommendations and 30 updated recommendations. And this is across different health conditions. And there's a new module for anxiety. This was not present in the earlier version of the guidelines, but now we have expanded MHCAP to include anxiety. And basically, it aims to facilitate implementation of WHO action plans by healthcare planners and program managers. The next slide. So now within these recommendations, when we were looking at the epilepsy module, there were a number of recommendations which came up for updating, but the one that is relevant here and I'll expand upon is the question that we asked, what is the effectiveness and safety of anti-seizure medicines in women of childbearing potential? Now, this recommendation has been looked at in the previous guideline too, but we thought it was important to update this information. And when the evidence was reviewed, this is what the recommendation led to, that lamotrigine or levetiracetam should be used as first-line monotherapy for both generalized as well as focal onset seizures. Women with epilepsy should have their seizures controlled as well as possible with the minimum dose of anti-seizure medicines and taken in monotherapy wherever possible. This is also an important point that when anti-seizure medicines are used, and you'll be hearing more of this from the panelists, monotherapy is a preferred option. And the recommendation that now is emphasized about valproic acid or sodium valproate, which is not recommended in women and girls of childbearing potential because of potential harm to the fetus. In the next slide. So this recommendation was made by the experts who reviewed the evidence for what was available. And it was a strong recommendation that valproic acid should not be used. Now, this recommendation is in fact in two places in MHCAP. It is within the epilepsy module, as well as within the module on psychosis, which speaks about interventions for the management of bipolar disorder. And as you know, sodium valproate is also one of the medications that is used for maintenance treatment for people with bipolar disorder. And again, there's a strong recommendation against its use for women and girls. The next slide. So the evidence that led to the recommendation was actually based on a high-quality systematic review that was done in 2017, where most anti-seizure medicines were associated with a higher risk of major congenital malformations in the offspring of women taking this during pregnancy compared to controls. The highest risk, though, was with sodium valproate, both for major as well as minor congenital malformations. Phenobarb, phenytoin, as well as carbamazepine were also associated with higher risk of major and minor malformations, and topiramate was also associated with a higher risk of major congenital malformations. The risk of congenital malformations was not significantly higher in women who were taking lamotrigine or levetiracetam, and that's why these are now the first-line treatments. And in fact, following MHCAP guidelines, what has also happened in parallel, that now levetiracetam is included in WHO's model essential medicine list, and in addition to the other anti-seizure medicines. So while these guidelines were being developed, the next slide, please. During the update process, we thought that it was important, and the recommendations were being finalized by the expert committee. But at the same time, an addendum was published on the WHO website to provide considerations for implementation when using anti-seizure medicines in women and girls, as well as for the treatment of bipolar disorder. And this, in fact, speaks about informed decision-making, which you will hear more about in the course of this webinar, information that should be given to women about pregnancy prevention, use of contraceptions, and the risks of valproate when taking this, if they are planning or they're pregnant, and what healthcare providers can do in women who are already receiving these treatments in terms of switching to alternate treatments. The next slide. Along with this addendum, what we also published was a safety statement last year on the WHO website, which again brought attention to the risks of using sodium valproate in the specific population of women and girls who are of childbearing potential. In the next slide, let me hand over now to Noah to take you through pharmacovigilance aspects of the use of anti-seizure medicines in women and girls. Noah, over to you.
Thank you, Nidra. And just to discuss, WHO has an advisory group that is comprised of experts and with equal representation from all regions of the world. And the advisory group on safety of medicinal products advises WHO, the Director General, on pharmacovigilance policy and issues related to the safety and effectiveness of medicinal products. And the advisory committee is convened by the pharmacovigilance department in WHO. And the committee meets twice a year. And one topic that has been consistently on the agenda is the risk of sodium valproate in women and girls of childbearing potential. And advice that has been given to WHO is centered by the committee, is centered around building awareness and the importance of communicating this. Important updates in the MHCAP guidelines to healthcare professionals and patients globally, so that informed decisions can be made. So I guess this webinar is a result of this recommendation and other efforts that we have been working together at WHO to improve the communication of this important message. I'll hand over back to Nirja. Thank you.
Thanks, Noah. And the next slide, you see now what we are doing in addition to dissemination of this recommendation is to basically also update the derivative products. So we have, I described to you the WHO intervention guide. We are now developing version 3.0, which will have these recommendations very clearly written down. The training manuals also will be updated to reflect the new recommendations in the MHCAP guidelines. And what WHO is developing and will publish in a couple of months is the MHCAP e-learning course on the WHO Academy, which will be a self-based learning for healthcare providers working in non-specialist healthcare settings to provide treatment to people with mental and neurological substance use conditions. And this online training course will also have these recommendations very clearly and explicitly described. Thank you very much. And I end here now and hand over back to you, Eugene.
So, Nirja and Noha, thank you very much. This was an excellent presentation on the new guidelines, and the importance is the dissemination and the implementation, what we have now, and therefore we have to all work together for doing this. And now we move on to the panel discussion, and the first speaker of the panel discussion is Professor Gus Baker And Gus, I'm very much looking forward to your talk. We will have, as I said, the discussion at the end. Unless you have urgent requests, put it in the chat and we can maybe answer it after Gus' presentation. So please, the stage is yours. Thank you.
Thank you. Could I have the first slide, please? So it's very clearly understood in a very extensive body of literature across the globe that epilepsy is associated with risk, particularly for women of childbearing age. The IBE is committed to empowering people with epilepsy to manage their condition, and we're also committed specifically to helping women with epilepsy understand the potential risks around pregnancy and getting the management of their condition at the time of the pregnancy correct. Next slide, please. So this publication on the left refers to the work that was done by myself and my colleagues in the UK and the US, including our speaker, Professor Pannell, where we looked at the neurodevelopmental effects of exposure to anti-epileptic drugs in utero, and were able to identify very clearly that the taking of sodium valproate during utero exposed the children to neurodevelopmental delay, and the IQs of children born to mothers taking sodium valproate were statistically lower than those children who've been exposed to other anti-epileptic drugs. But that's just only part of the story. We were able to demonstrate over the last 15 years now that the risk of neurodevelopmental disorder is about 6 to 10 times greater in children exposed to sodium valproate than those who did not. That higher rates of autism spectrum disorder is seen in children, particularly for those who are exposed to sodium valproate, and that prenatal exposure to anti-seizure medication is also associated with very clear cognitive difficulties, including verbal, social, and attentional difficulties. But of course, sodium valproate is the first line of drug for women with generalized seizures. Obviously not now since the recommendations of the WHO, but it is the most efficacious. So we need to think about the research that's acquired across the ASMs to delineate this risk. If you're a woman with epilepsy, you need to understand what the risks are associated with their anti-epileptic drugs. And those children whose mothers were taking drugs, anti-epileptic drugs, at the time of their pregnancy, they really need to be monitored following their birth to look for potential early intervention. So our job, certainly from the IBE perspective and from the ILAE perspective, is to try and ensure that women with epilepsy understand the risks associated with having children when they're taking sodium valproate. Next slide, please. So one of the things that we've done in the IBE is to try and understand what the experience for women with epilepsy is. And we did a survey over around Europe that involved 900 women with epilepsy. And we asked them about their experience of pregnancy, about the experience, the management of their epilepsy, and while pregnant, and even when they're not pregnant. And the results can be summarized quite simply that some of the respondents received good advice, others found information frightening and confusing. And some, as a result of what they had heard and understood, decided against having children. The availability of information that was clear and reliable and valid was not easily accessible. And the main sources of the information that was necessary for understanding the risk came from neurologists, gynecologists, and the internet. Now that when we talk about the internet, it was not from support groups, but the internet generally. So few women used epilepsy organizations or support groups for information related to their pregnancy. And membership of support groups obviously varies, and it varied across this particular sample from 10% in Russia to 75% in Italy. Unfortunately, many women learn about anti-seizure medication risks only after becoming pregnant. And in our respondents, there was 60 to 90% based on which country. Most taking ASMs during pregnancy. Most were taking ASMs during pregnancy. Medical advice and pregnancy planning was extremely variable, with the majority would consult doctors before stopping medication if pregnant. So there needs to be a very clear shift in the way that we manage this condition in respect of ensuring that women get advice well in advance of deciding to get pregnant and at the beginning of their career of potential pregnancy. So 34 to 60% of pregnant women with epilepsy did not receive any advice in relation to planning pregnancy. So we need early proactive advice from healthcare professionals. And that advice has to be reliable, it has to be valid, and it has to be easily accessible. And this is a survey that was only conducted 3 years ago. So we still have a significant amount of work to do. Next slide, please. So there is a role for patient advocacy in sharing policies related to epilepsy and pregnancy. This is a program that has to have a multifaceted approach. It's got to involve patient organizations, it's got to be globally cooperative, and it's got to have the power of lived-in experiences. There are many patient organizations who provide good evidence, but not all women with epilepsy are members of these groups. So we've got to actually think outside the box and use other platforms like social media to reach a much broader audience. And we've got to use a more global and inclusive approach. I know that there has been surveys conducted apart from our own, but I'm not aware of certainly surveys conducted in low or middle income countries. So we have to think about how we address that. We need to have advocates and organizations and healthcare professions supporting the provision of advice globally. And the IBE and the ILAE have a substantial role to play in this. But also lived experience in shaping policy and decision-making in healthcare planning and service and delivery is essential. We need to engage and involve women with epilepsy globally in these efforts. Patient organizations can help identify and amplify the voice of these advocates. Next slide, please. If we look at a web search, we can identify the sort of issues that women with epilepsy are asking about. And we know from the work that's done to date that many women ask questions about, can epilepsy cause a seizure during pregnancy? Can a woman with epilepsy have a healthy pregnancy? Can a pregnant woman die if she has epilepsy? And these are questions that are fundamental to the understanding of the risks of epilepsy. And we need to ensure that we come together to take a very clear and consistent approach in answering these questions and do it in a way that allows the majority of women to make sure that they can access such information. Next slide. So we are working in epilepsy to try and improve the way we communicate information about epilepsy, and we have a website that's committed to providing basic information. But we need to look at initiatives like the International Women's Day, that we can share resources on social media so that we can ensure at least that people who have access to media will be able to access information that's reliable, valid, sensitive, and addresses the immediate concerns that they have about having a baby or not having a baby.
Thank you. Thank you so much, Gus. That was excellent, and I'm really impressed by the survey. There are some questions to you, Gus, which is important. So the survey was done in Europe.
That's correct.
This Europe, the region Europe has low-income countries, high-income countries. So what is your thought about the other countries and the external validity to talk about or to address the global problems?
Well, I think if we have a problem in some of the middle and high income countries in Europe, I think it's fair to say that we're going to have a substantially greater problem in lower income countries, where we know that the opportunities to access information in relation to epilepsy in pregnant are going to be much more difficult. And one of the things that we probably need to think about is replicating this survey in countries where they don't have the same level of facilities and the same level of organization. And I suspect that despite the very best efforts we've put together so far, there will be still a substantial number of women who really don't have access to the sort of information that they would need to have in order to make decisions about their pregnancy and get the best management of that pregnancy.
Okay, so the other question I have to you is, you are an outstanding neuropsychologist and one of the persons who really brought that forward with scientific research, that the effect of the offspring of the mother of the children is so fundamental. When you did the survey, I did not get it from the detailed results. What was the major concern? Was it malformation or was it neurodevelopmental delay? What are your thoughts on that?
I think that the neurodevelopmental delay is much more important. It's much more prevalent, and it has a lifetime effect. And so it's really important, I think, that we understand, and we do certainly in relation to sodium valproate, what the potential risks are. What I'm concerned about is that we probably don't know as much about some of the other anti-epileptic drugs and whether they have potential for having similar effects. If you ask me about sodium valproate, I can talk to you for hours about the cognitive and neurodevelopmental effects of that. What I can't tell you about is research that's identified that there may be issues with other anti-epileptic drugs. And I think this is ongoing research. I know that Professor Pinnell, I'm sure, is going to address this in her presentation as well. But we know that if you're taking sodium valproate, and it is the drug of first choice for women with generalized epilepsy, you really do need to think about what the consequences and risks are for your children. And that has to be a fundamental aspect of the management of that condition.
Yeah. Thank you. Thank you so much. I couldn't agree more, because there is sometimes a delta, a gap between what doctors think is of importance and what is important for the patients. And I think this is the right way to work together and to collaborate and to ask the right questions. So thank you so much. And we will come at the end again to some of the issues you brought up. Thank you, Gus. So, and I think we have the next speaker, Fatima Dewan, now at the stage, and we take you. Can you speak from the car while you are on the
I can. Just ask me the question.
I think it's quite important. We heard about the guidelines, and the guidelines are for risk minimization, right? That's very clear. But one thing which is important when you have guidelines is the dissemination, number one, and one part is what we do now. And the other one is the implementation. And the third point is the adherence. So let me ask you, how do you think we can best implement the guidelines?
Actually, thank you for the question. The guidelines are very clear and very precise and very specific. Like in pregnancy, in epilepsy in pregnancy, there are guidelines for the preconception counseling. There are guidelines for the monitoring during pregnancy and also during lactation. And these have been made by the Society of Neurosurgeons of Bangladesh. They have prepared this, neurologists of Bangladesh, they have prepared this guideline along with the OB/GYN specialist. Now, one thing is when a woman, there are some basic principles which everybody follows. Like when do we, in the pre-pregnancy counseling, when do we advise the woman to get pregnant? When she gets pregnant, how do we follow her? How do we monitor her? So when women are coming with epilepsy, there is a combined consultation with the neurologist and the OB/GYN specialist. And the woman is advised, well, she's taking the drug. Now, whether she's seizure-free for at least 1.5 to 2 years, number one. Number two, she's told that if she takes pregnancy, in 90% cases, there's no problem with the baby. Number three, during preconception counseling, she is advised to take folic acid. And if she's on drug, then we should change the drug, and that drug should be, it is a valproate. Then valproate should be changed to levetiracetam and all that, and also the deoxycarbamazine, and that will be during the pre-pregnancy time when she is planning to take the pregnancy, because it's no use to change it once she becomes pregnant. Now, when she becomes pregnant, the thing is that the blood should be measured. So this is a challenge in our country. Like when she is pregnancy, the sonography scan is done, the congenital abnormalities tried to be detected and all that, those are okay. But the monitoring with the blood level of the drug, that is not always in place. And the second thing is, when the woman is continuing during pregnancy, the monitoring with scans are done, okay? But this is a big problem. Then when she goes into labor, the dose of the drug should be reduced and she should be monitored. If she suddenly develops seizure, she needs to get a cesarean section done. So these things are followed to some extent also. But my comment is, in Bangladesh, we need to be more particular about the dissemination of the guideline, number one. Number two, whether and there is exactly no study as such, no evidence as such, which will tell us that women taking sodium valproate, whether there is a congenital anomaly of the fetus and whether it has been reduced due to the strict adherence to the monitoring process.
Thank you. Thank you very much. That was quite clear, and I also have to say quite impressive. My personal opinion to the serum level measurement is they are quite predictable, that levetiracetam and lamotrigine, they decrease dramatically quite early in the pregnancy, and then they have the reverse. So even without measuring precisely, you have to adopt the dose, which is important, and I think that's also included in the guideline. My other question, which I want to ask you, is, for me personally, it's always one of the difficult things. Once you have that implemented, let's say in the hospitals, in the neurology, in the pediatric, in the gynecology departments, etc., how do you assess adherence, or how do you keep up adherence to the guideline? Because there's a usual decay in knowledge, personal stuff is changing. So guideline adherence, what are your thoughts about that?
Guideline adherence is not so up to the mark, although people are doing it. Like suppose I am an OB/GYN specialist, I am looking after a woman. I will always consult with the neurologist. The neurologist will see the patient. I will see the patient. We will consult. We'll give drugs. But it's not that I am, if I am an OB/GYN specialist, I'm not talking about myself, regard the other ones, it's not always being followed so strictly, the monitoring one, which should be. So I think there is a scope of increasing the adherence to the guideline, the scope of doing some advocacy here, so that the OB/GYN specialist and the neurologist, they follow this, because we are not looking after these women ourselves. We are telling them to consulting them, and they should also, we all should do it in a more better way for the better outcome of the woman.
Yes, I think that's a very important message. And for me, in a high-income country, the collaboration between the doctors, all serving to the best care of the women, is sometimes which we have to approve. So
another thing regarding the vitamin K, the woman should be given vitamin K, and also the newborn should be given vitamin K. So this is also followed, because in our country, vitamin K is always given to the mother after delivery in normal instances. So when it comes to this epilepsy in pregnancy, it is followed. So it is usually given.
yeah, good. Thank you for that comment. And I think, Annabelle, if I'm looking on my old-fashioned watch, I think we have to move to the next panel discussion. And Farhana Dewan, thank you very much for your input. That was very important, and thank you for being here. Whenever you have to leave, please just do that. And I see that you are under time pressure, but it was very important
Thank
that
you, sir.
we have you here. Thank you so much. So, and I think thank you. The next speaker is Dr. Paige Pennell. So because you work in a high-resource setting, typically USA, and can you walk us through slowly to some of the best practices that you guide decision-making when caring for a person with epilepsy during pregnancy?
Yes, first of all, thank you for having me, and kind of giving you, as I talk about it, a little bit, if it's okay, historical perspective as well. So I think there's so much that has already been addressed by the prior speakers that's so important, which is women's fear, their fear that their baby's not going to be okay, and the fear by them and their family members that their seizures are going to get worse, life-threatening. And that's what I encountered early in my career. But we didn't have the evidence to know how to counsel them. So I will say that we've gotten so much more information to be able to address their fears and communicate that. And the first thing I give is hope. And really tell them we're going to get through this. The chance your child will be the same as your sister's children, maybe if your sister or your neighbor doesn't have epilepsy, the outcomes are, we can get it as very, very close to similar low risk with the correct medication choices. The other thing that I really emphasize is the seizure control. So early, sort of historically, the part that's important is when the risks for valproate were first recognized for malformations and then later neurodevelopment, everyone was terrified to not use valproate and to take women off valproate. So this was for prescribers. But now we have information that clearly shows, even in the idiopathic generalized epilepsy, we can maintain good seizure control with other medications. And so specifically, we're at the end of a 10-year study called MONED, and we have a paper in New England Journal of Medicine that showed our women in our observational cohort did not have seizure worsening and did not have any differences compared to women who were not pregnant. And the majority of the women in our cohort were on lamotrigine and levetiracetam, which are consistent with the current guidelines of what is recommended as first-line therapy in women of childbearing age. So, you know, a lot of it is starting with hope, but how we get there early as far as talking about medication choices and how we dose those medications during pregnancy.
So I think that that was very impressive, because you said something which is important when the patient comes in, and that's the hope. And that is when everything is in order. You think about becoming pregnant, you're planning the pregnancy, you go there, and you have the ability to guide these family and the women with that. So what are your steps when this does not happen in that way? How do you handle that when it's already too late? For instance, a woman comes in week 12 with valproic acid and say, oh, I discovered. So what are your steps there?
Yeah, so it's a good point, because even in high resource countries, 50% of pregnancies are unplanned in our general population. And some studies even indicate that the rates of unplanned pregnancy are even higher in women with epilepsy. So this is a common thing. It also gets back to, starting at puberty, we really should avoid prescription of valproate, but we know it's still occurring. My personal approach is not necessarily the same approach as other neurologists, epileptologists. I personally feel that at 12 weeks, we can still lower the risk by changing medications for neurodevelopment, not for malformations, obviously. But in our studies that we've done with Dr. Baker and others, it does seem as though the third trimester exposure particularly drives the risk for neurodevelopmental disabilities. So I like to engage in, as you said, a shared decision-making with the patient and our family. Here are different options. Of course, every woman's different with regard to her seizure severity. If she had already tried the other medications and failed other medications, that's a very different story than if she had never tried levetiracetam, is the one medication that is easier to switch to during pregnancy. I never changed to lamotrigine during pregnancy. Unfortunately, I've had those patients seen in my clinic after other people tried to, and then they had the rash with the rapid change, Stevens-Johnson. And also because of the changes in lamotrigine metabolism during pregnancy, you really just can't get to a good dose quickly. But the one medication switch that is very relatively smooth and easy to do is valproate to levetiracetam. Now, again, many physicians, many patients will not choose to do that. Or if they had failed levetiracetam before and we're still having generalized tonic-clonic seizures in particular, and they need to stay on valproate, then the next approach is really trying to get that medication level as low as possible, because we do have very good evidence that the risk on the fetal brain development is related to the concentrations, how high the concentrations or doses are during pregnancy. So we do try to at least get the dose lower. And for some people, this is one where polytherapy with valproate at very low dose and another medication to keep that valproate dose low is actually preferred over valproate monotherapy at high doses.
That's very important. That's also a change in practices, which you mentioned, because previously you said, well, that's too late after 12 weeks. And no, it's not too late, because the neurodevelopmental delay is still ongoing. Therefore, it is worthwhile. And I got the message. I learned to lower the dose is something which is important. And when you add, there's a preference of levetiracetam over lamotrigine due to the pharmacology of the drugs, the high risk of skin reactions. That's very helpful. Thank you. And the other thing which I want to ask you is about the seizure control. Once you are in the situation to lower the drug, which you have to consider, so what do you do when a relapse seizure occurs or when seizure activity starts in the second or third trimenon?
Yeah, so a lot of people refer to this, and this is part of my own, sort of emphasis of my prior research, because early when the message was lamotrigine had a safer profile. We didn't know that we needed to adjust the dose and that the levels would fall. And so people were appropriately reporting, seizures got worse. We can't use lamotrigine because the seizures will get worse. And then that's when we realized, well, it's because of the pharmacokinetic changes, it's how the body metabolizes the medication, that we need to just actually do therapeutic drug monitoring and adjust the doses. So since then, we've done work on a lot of medications that show similar findings. And so we do recommend the therapeutic drug monitoring, as Dr. Dewan also pointed out, and maintaining that person's particular concentration. So for some women, depending upon her seizures, it could be at the lower end of typical range for the medication. For others, it could be a little bit higher. But I also want to address another thing that you brought up, Dr. Trinka, that if you can't do therapeutic drug monitoring, there are, we have another paper out from our recent MONEED study that showed the changes in the levels of most medications. And it is relatively fairly consistent between individuals. If you can't do therapeutic drug monitoring, you can use that to then say, okay, and by this week I should make this adjustment. And so you can use that as a guideline. And the other thing that is very confusing for patients and also for doctors is these changes happen very early on. It's not when weight gain occurs. So we ask our patients as soon as they find out they're pregnant to call us. I mean, they can let their partner know, but then they need to call us, not to wait until sort of when they're telling their employer at 14 weeks, because we start that process of adjusting doses early on, and that's how we prevent the seizures from recurring or getting worse again.
Okay, thank you very much. So you're not the first to get the information, you're the second.
Right, we hope so. Right.
But it's very important to make these adjustments early. So thank you very much. That was very exciting. I would love to talk for hours about that topic, but we are running out of time, and I got already the sign that we have to move on. Thank you very much, Paige. And we're moving to the next speaker, and that is Melody Sukile. And now we have heard from a high-income country, but there's also the question how you handle this, how you make the shared decision with the women in the childbearing age wanting to get pregnant in a low-income setting. So, Melody.
Thank you very much again, and thank you to ILAE for inviting me. I think firstly, thank you as well to Dr. Paige just for that introduction. And those are the principles that we go by, the best practices she described. I mean, that's what we aspire to as well in Zambia, which is a low and middle income country. I think some of the things to highlight are the challenges that we face when we manage women with epilepsy. So just looking at it in the background, we know that the burden of epilepsy is highest in our region. And then epilepsy tends to peak mostly in the reproductive years. One thing that we really struggle with is the stigma and cultural barriers, the myths and misconceptions around epilepsy. And so there's often, especially in the more rural areas, there's social rejection, failure to fulfill roles. And this becomes even more evident in women, and particularly, and even more so in women with epilepsy. One of the biggest challenges that we struggle with is limitation to access to healthcare. And this is not just primary healthcare, but even specialist healthcare. I heard Dr. Prana talking about how they'll have a clinic with an obstetrician and a neurologist combined to the woman. But in my country of 18 million, we've got about 10 neurologists, so then that becomes impossible. Things like access to drug monitoring becomes difficult. High rates of HIV also come into the mix. So it becomes quite a difficult situation when we think about women with epilepsy. So the issue really is also to do with reproduction. So if I think about what are the things that I have to deal with in a woman who is in her reproductive years, So I think in personal experience, one of the challenges we have is a lot of patients who come to us with epilepsy or who are pregnant, they'll present to a health facility quite late in their pregnancy. So maybe by the time they come, it's most often after 16 weeks. And so then you are dealing with trying to see how you can adjust the medication. And then also now, the biggest challenge is access to medication. So it's good that levetiracetam and levetiracetam has been included in the essential drugs list now. So that hopefully will improve access to medication. But in our clinics, if I talk about our hospitals, what we have most available usually is carbamazepine and phenobarbital. So most times what we'll do is we'll choose rather to use carbamazepine because it's a safer option. And then occasionally, if a woman is on sodium valproate and she's got generalized epilepsy, then what we'll aim to do is try and use the lowest possible dose. We are not able to routinely check drug levels. And so we really just go by some of the trends that were described and then looking at the epilepsy control. One thing that we do in our practice is, firstly, when women come to us, is to explain what epilepsy is and what it means, because for us, that's actually the first step where they're really afraid, is they don't know what it is. There's so much myths around it. They don't know what it means for themselves and the baby. So I think explaining the diagnosis. And then secondly, it's explaining the importance of medication. In our setting, we also have a lot of mixture of treatments. So a patient does come to the hospital, but then they're also seeing a traditional healer. They're also seeing spiritual leaders, and they might be mixtures of treatments for the condition. So not always perfectly well done, but trying to see how there can be better communication between these, among these different groups, but then also really counseling women to be open to us and tell us if they feel they're changing their treatments or if they're taking other treatments, because that can have a serious impact on the treatment that we're giving them. So wherever we can, we try and use levetiracetam, but as I mentioned, it can be really challenging. But I think as well, the one thing which can be challenging is where the diagnosis of epilepsy is actually made during pregnancy. And so it's in this case that wherever we have, say, levetiracetam available, we'll try to get that, and we'll avoid using sodium valproate. But it can be very difficult. But yeah, those are some of the ways that we try and get around it.
Well, Melody, you already addressed some of the questions which I wanted to pose to you, but if I may follow up on the question of availability of levetiracetam. So you said that you have valproic acid, phenobarbital, carbamazepine. These are the most often used drugs, but as you know perfectly well, that carbamazepine doesn't work in idiopathic generalized epilepsies at all, so you need something else. So what is the role of levetiracetam? Is it available? And there is, of course, it's on the list of essential medicines, etc. Is that already in clinical practice, or are you lagging behind, unfortunately?
Thanks again. So in urban centers like in Lusaka, we have levetiracetam available privately. So patients can acquire it like in private pharmacies and so on. But right now, that's what I was saying. It's really good that the WHO has put it as the essential drug. So I am optimistic that we'll soon have it in state hospitals as well.
Yeah, thank you.
Children's hospital, yeah. So that's where we're going now. So right now, patients who have money, they can access levetiracetam, lamotrigine. But when we go to the rural areas, there's really only carbamazepine and phenobarbital.
Yeah. It should not be about money. It should be about equality. And levetiracetam is a very cheap drug to produce. So that should be something we have to carry forward. And the other question you addressed briefly, and that was education. So how do you educate in rural areas that they know, well, go immediately, like Paige said, the first doctor to call after the husband is the one taking care.
So in our setting, what the individuals who are most helpful with primary healthcare are people who are called community health workers. So they are taught like basic information about different diseases, and they actually go into the community. Sometimes they hold meetings at a market, for example. They'll go to schools. So how we try to engage them is having training for such cadres, community health workers, and then through them, getting them to speak within the community. Community health workers are usually people who are like community members trust, and they rely on, and they feel they are on the same level, because as a medical person, you are viewed as if you don't fully understand what's going on in the community. We are not doing it so well at the moment, but I think other groups in Africa have also tried to engage traditional healers. In many studies here in Zambia and also like in Nigeria, it's shown that more than half of people with epilepsy will first seek treatment at a traditional healer before coming to the hospital. So there are some programs where medical professionals are trying to engage with traditional healers to see how we can discuss co-managing these patients, or at least understanding what are patients' perceptions about treatment. So going into the community, I think also engaging, we have a lot of reproductive health education programs in schools, and so perhaps bringing in comorbidities like epilepsy for girls and training them, especially about, say, the use of, I think that those are some of the ways we can improve it.
Okay. Well, thank you very much. That is also something which is very exciting, because these are, of course, key issues to have the community engage with the primary health care physicians and with the traditional healers. And I think that would be very important to have teaching programs involving all the people taking care of women in that respect. So thank you very much. That was exciting and extremely interesting. And I think there's a huge importance. Thank you, Melody, again for being with us. And we have questions at the end. And for the audience, please, you listen to that. If you have questions, put it into the chat, and we are happy to answer it afterwards. But before that, the next panelist, Dr. Richard Hill, waiting so patiently, but this is something which you need when you are dealing with regulatory measures and policies. That's a long way to go, but I still think it's very important to have also your view on the regulatory measures which are now in place to ensure that women with epilepsy will truly have access to preconception counseling and care globally. So what can we do about that?
So I'll just start by talking about some of the measures that have been put in place. I'm talking from the point of view of a medical regulator in a high-income country. So here in Australia, we've heard that information is very important, access to the correct information, and not just from doing a Google search. So information has been produced tailored towards both patients and healthcare professionals. For valproate, the boxes are now labeled with a pregnancy warning, so from the manufacturer, rather than just a label that someone has to stick on. And there's a patient card that is provided by the pharmacist, so that's reinforced every time someone goes to get a new prescription. In the UK, there's a pregnancy prevention program. So the use of valproate in any woman under the age of 55 requires the approval of 2 independent specialists. And then there's an annual informed consent. So that's reviewed annually and acknowledged by that patient, goes through the risks. So that's what's in place currently for valproate.
Richard, when you have these rules in place, they sound very reasonable and quite strict. And for a prescribing doctor, I think that's very important to reassess whenever is a woman on valproic acid, you have to think, is there something else? And these cards, these letters, they all help do that. But my question to you is whether you have any ways to measure whether these rules are followed. Is there a decrease in the rate of malformation, or is there a decrease in, let's say, complaints when there is something going on, that a doctor did not take off valproic acid despite the measure? So how do you measure the effect of the policy?
A lot of the information that we have about congenital malformations in women taking anti-seizure medication comes from pregnancy registries around the world. And these pregnancy registries have been going for a long time. The one in Australia has been going for 25 years, and they're still ongoing. They're still collecting information. And regulators are very interested in this information because it's one of the major sources. So the Australian Pregnancy Register has shown a reduction in the use of valproate and also a reduction in the dose of valproate in women with epilepsy. It can also look at the kind of the doctors that are prescribing. So whether it's being prescribed by a neurologist or a general practitioner that might target the kind of intervention that you would want to carry out. And we've heard that valproate is used in other situations as well. So we also have to be mindful that valproate still can be used in bipolar disorder. So that can also be monitored using these registers.
Yeah, I think that is one thing which I want to highlight, the importance of the registry. So there will never be a randomized controlled trial, but there will be new drugs on the market for women with epilepsy and childbearing potential, but also for younger girls. So, and it is very important to have these registries. For rare diseases and very expensive medications, some healthcare systems ask the doctor to register the patient in one of the registries. For instance, spinal muscular atrophy, you have to register. Otherwise, this will not be reimbursed. Is there anything that you have, in addition to the leaflets, in addition to the information, that you have to register this patient in a pregnancy registry?
Look, here it's an opt-in, and it's often self-referred by the patient rather than by the prescriber. But I mean, there's a number of other regulatory measures that can be taken, and there's across a wide range of regulators. It's not just necessarily focused on the medicine, although, I mean, we heard from Zambia that regulators are important to make sure there is availability of alternate medicines and that they're funded, so they're available for both public and private patients. And that includes not only anti-seizure medicines, but contraceptives, for example, that there's referral process in place, a streamlined referral so that women can get easy access to a specialist, adequate training, and also appropriate healthcare professional workforce is available, includes not only general practitioners, specialists, but also support staff. I mean, we haven't really spoken about psychosocial support, but that's important. And then regulators provide a lot of research funding as well. So to be aware of where the gaps in knowledge and what's the ongoing need for research. And so that does involve a close working relationship between the regulator, the healthcare professionals, and the independent bodies representing patients.
Well, thank you. That's important. So I can only apply to all colleagues taking care of women with epilepsy to go to the local registry, Australian, to the Europe, and to the US registry. That's very important to gain additional data. That's not the end of the story. We will have new drugs, so we need this information. So thank you very much, Richard. And I may ask now all panelists to come or switch on their video because we will have some some questions. So we have one, I think that's a very important question by Tahir Obeid. He asked that is there any relation between the dose of valproate and neurodevelopmental delay in the incidence and also in the severity? And I think you addressed it briefly, Paige. And the second question is regarding the men, but let's tackle first the first one about the dose-response relationship. Paige.
Sure. Dr. Baker can also add in. So in the studies we did together that he mentioned, we really did see a dose response relationship, that there were worse verbal developmental outcomes, for instance, with the higher doses. We didn't have blood levels for that study. However, the autism study, which wasn't through my work, but through others, really showed that the risk for autism was there no matter what the dose. So I would just caution, if you need to use valproate, yes, try to get it as low as possible, but don't translate that to, well, if I keep the dose low, there's no risk. And so in my last 15 years, there's one woman I specifically had to keep on valproate to keep her convulsions controlled. And I kept her between 250 milligrams to 375 milligrams per total per day. But again, in using with a combination with levetiracetam to keep that as low as possible. But if okay, can I turn it over to Gus for additional comments, because he's done a lot of this research.
Yeah, well, I would just say exactly what Paige has said, that the lower the dose, the more likely there is going to be less an adversarial effect on cognition. And so all the advice today about lowering the dose to the least possible level is advice that I think we definitely want to follow, because it is clearly associated with less cognitive effects. But of course, it doesn't mean there are no cognitive effects, as Paige has suggested. It just means that there is going to be less of an impact. You know, we have to be clear about this area, particularly neurodevelopment. We don't know what the long-term effects of exposure to anti-epileptic drugs in utero is. We haven't got any long prospective studies that have looked at what children are like when they're 10 and 12 or 15 years of age. So we don't know what the effects are. But what we do know, what's simple and basic, is that you need to minimize the risk as much as possible during the pregnancy of neurodevelopmental effects. And that will be lowering the dose. It'll be about folic acid. It'll be about getting that information and knowledge out to women before they even get pregnant.
Now, thank you very much, Gus. There's another question which I'd like to address to both of you, Gus and Paige, and that's about the male taking valproic acid. Is there any neurodevelopmental delay in the offspring, or is there any teratogenic effect of the male taking valproic acid to the offspring?
I really would like Paige to start on this one, and I'll come back to it, because I think it's an interesting area, and it's clearly caused a lot of controversy, particularly in Europe, and I suspect for the rest of the world as well. But Paige, over to you first.
Yeah, that's why we're both smiling and laughing. It's no laughing matter for certain, no joke.
No.
But I think many of us feel that there was one signal that was followed up on with a very pretty extreme sort of announcement about concerns about valproate in men and their offspring, whether having potential for risk for neurodevelopmental problems or malformations. But the data wasn't clear. It was, sort of things from different industry, pharmaceuticals, et cetera. However, there was another report that came out that was a beautiful, wonderful study that just came out that debunked that myth. Now, it doesn't mean we don't need to do, of course, we need to do more research. But I think just what we know from embryology, from how, it goes from the sperm and the egg to a full baby, it's just, and everything we know about teratogenicity, it is so much about the exposure the medication during that developmental process. And so I personally was very happy to see that study that was very rigorous came out to really make me feel that that risk is probably not negligible. Again, you know, there's always things we need more research on, but I'll turn it over to Dr. Baker, may have a different take on it.
No, I have to say that the actual signal that was first released through that study really sent some shockwaves through the community, because it was not an area we'd actually thought about the contribution of the father to the neurodevelopmental delay. And I think that the second study that you just cited was really important, but it's not as yet changed practice in Europe in respect of the need for 2 neurologists to be involved in the administration. And, you know, we've only got 2 studies to draw upon to actually inform and advise the scientific community on. And it's clearly an area that perhaps we should do some more research on, but there are other priorities.
Okay, well, I have now a question to you guys, to Paige and to Melody. So what are your top 2 anti-seizure medicines for women in childbearing potential? So I start with you, Melody. What are your top 2 choices in your...
Again, my top 2 are still levetiracetam and lamotrigine, and wherever possible I use that. But then my third option is usually carbamazepine in women who don't have access.
Okay, so 2. And then it's levetiracetam and lamotrigine. And Paige, what are your thoughts?
Yeah, my top 2 are lamotrigine and levetiracetam, given the really abundance of information about low malformation risk and also abundant information about low neurodevelopmental risk. Yeah. If I can just back Melody up on the carbamazepine, I agree in focal epilepsies, and also you don't have to adjust the dose that much if you don't have therapeutic drug monitoring. The malformation rates are a little bit higher, but we actually had really good neurodevelopmental data that the risk for the brain development is very low with carbamazepine, going back to studies with Dr. Baker. So I agree to keep it on the list if you can't use lamotrigine or levetiracetam or the patient doesn't respond to them.
That is a follow-up question, but I agree with you completely. And Gus, what are your top 2?
Based on the neurodevelopmental evidence, lamotrigine and levetiracetam.
Okay, great. I agree with that completely. So Nerja. So we have now a doctor saying these 2 drugs should be available in every country. And the question to you is, what do you do? And what are the plans to get these drugs to all of the countries? And what is the regulatory framework, or can you help in any aspect, Richard, to support that these 2 drugs are available globally? So first you, Nerja.
Thank you. No, thank you. This has been a really interesting webinar so far. So I think the first step that we did was to have this in the recommendation. We now have it in WHO's Model Essential Medicine List. So we have these drugs included in the Model Essential Medicine List. The Model Essential Medicine List now acts as a guide for countries and as an opportunity also for countries to have this within their National Essential Medicine List. So that's what now the focus needs to be. So countries, and we have experience of working with a few countries in the African region where now they need to examine what their standard treatment guidelines say about, what anti-seizure medicines to use, especially in this population, to re-examine these, to update these, and also then to update their National Essential Medicine lists to increase the possibility that these drugs are available and available to countries without causing catastrophic health expenditure to people who need them. I think that's the important thing. In terms of what else can we do, so we in fact in WHO are focusing on how we can improve access to medicines for neurological disorders. And in fact, epilepsy, anti-seizure medicines, and medicines for Parkinson's disease are the tracer conditions that we are focusing on to look at. So there are landscape analysis that has been done, like where are we in terms of the availability, affordability, and accessibility of these medicines? And what can be the approach if you're looking at how to improve access to these medicines, especially in low and middle income countries? So this report is going to be published, in fact, around World Brain Day, which is at the end of this month. And hopefully that will also serve for as a guide for when we are thinking about improving access to medicines beyond just valproate, carbamazepine, phenobarb, and phenytoin. But now how can we move the needle in terms of greater accessibility to safer medicines?
Yeah, well, thank you. Thank you. That sounds very good. And I'm very optimistic that there will be a major change in the next years. So anything to add from the regulatory perspective, Richard?
Look, the only thing that's of interest is that there's a big move towards regional regulatory groups so that individual countries don't need to do everything themselves. So see within the Caribbean, Africa, Southeast Asia, and the Pacific, formation of regulatory groups with the support of WHO or with the support of a major regulator. So Australia's been doing work in the Pacific and Southeast Asia, so that countries have a strong regulatory framework to ensure the safety and quality of the medicines that are being used.
Yeah, thank you. Thank you. So we have 2 questions in the chat asking about preconception counseling. And that's a very important issue. So it is, as we heard from Paige and from Melody, this is done in different settings. So what are your thoughts on that? So the question is very directly, if the patient takes valproic acid before being pregnant, what should you do about that, and how to stop, etc.? What are the things about how do you counsel? So whoever wants to start first. Melody, Paige.
Melody?
Paige, why don't you go from your high income setting?
Well, I think even when they're on any anti-seizure medication, I do think the importance of planning is contraception is really important. And so I do think we should be having those conversations, as soon as puberty. So I'll ask the parents. My trick is I ask the parents to leave the room, during the exam, and that's where we can, talk about some things and say, can I also talk about it in front of your parents as well? But a lot of times, of course, people will say, they're not planning, or maybe they're not sexually active yet. So I remind them that when they get a serious partner, they're not going to call me then. So we need to have the conversation now about what the importance of good birth control. So again, especially with valproate, but even others, and kind of go through the different options. I'm fortunate to work with my gynecologist partners. I'm not the one prescribing the birth control, but again, talk about how important it is to have a planned pregnancy, and especially if they are on valproate. There's very high efficacy rates of long-acting reversible contraception such as IUDs. So we definitely suggest that as one option. But again, planned decision making. Many females, some of them don't want to consider that option, which is totally totally understandable. And so we talk about different options. The one thing I just want to also add, someone mentioned before, it might have been Melody, is we also, as soon as someone is of childbearing potential, I start folic acid daily, because again, the chance of unplanned pregnancy is so high. So ask them to start taking folic acid every day, regardless of their, their sexual activity at the time or their plans for pregnancy.
Great.
Thanks.
Okay.
Oh yeah, thanks, Paige. So I think it's very similar For us, if I speak to contraception counseling, sometimes there are also myths and people tend to be quite secretive about it, but it's actually relatively very accessible in terms of the different options. But recent reviews, like in Nigeria, Senegal, they show that majority, at least more than half of women with epilepsy are still on hormonal contraception. But I do see that as an opportunity. So for my patients in the clinic, I also try to have those discussions with them, keeping them on folic acid, in explaining the importance of the interactions of the drugs. And I refer them to the family planning clinic to just discuss other options like the intrauterine device. And for some people, just barrier methods like condoms, for example. But I still see it as an opportunity that more can be done. I think, as I mentioned, even just from high schools already talking to girls about options. And I also feel speaking to family planning counselors. So most of our clinics, contraception clinics, are run by nurses. So I think having awareness among them about these interactions, because they might be thinking about contraception for just a woman rather than a woman with epilepsy and what that means for her. So I feel there's an opportunity there to improve the type of contraception that we offer.
Thank you so much. That is quite interesting. And as I said previously, we could run for another hour, but time is ending now. And there are two questions which I think is important. You kind of brief answers. Teratogenicity and influence on neurodevelopmental outcomes with oxcarbazepine and clonazepam. Is there a sign, or are they more on the safe side? What are the data telling you? Age.
Yeah, I'm glad to start. So oxcarbazepine is actually has relatively low malformation rates, not as low as lamotrigine and levetiracetam, but especially in the URAPS pregnancy registry. It was shown to actually have lower birth defect rates than carbamazepine. However, we don't have the neurodevelopmental data on it. So we do have some of it in this recent study we finished called MONED, but not enough to separate it out as an individual group. I mean, I think we have enough experience to think it's not likely to be a valproate story with neurodevelopment. If someone comes in, there's well-controlled focal epilepsy with oxcarb, I definitely don't take them off of it and switch them unless they want to, but I don't, recommend that. Then clonazepam, the data is really like where you lump all the benzodiazepines together, and the malformation rates are higher for that, especially cardiac. And I have real concerns about on the neurodevelopment of any of the benzodiazepines, including clobazam, which is what we're seeing more. But if I can let others, including maybe Dr. Baker, comment, especially on the neurodevelopment or anything else, or anyone chime in.
Yeah, very, very quickly. When I first started off doing the neurodevelopment study, they said that sodium valproate was a very, very safe drug and there was no neurodevelopmental effects associated with it. And it isn't until we've actually got the evidence in well-designed, well-sourced studies to be able to actually comment on any of the drugs. And so there is an absence of evidence, which does not mean evidence of absence.
Mm-hmm.
Great. So the last question, very short one, is related to mortality. We were talking about pre-counseling, choosing the right drug, having the problem of teaching programs, etc., and the non-availability of the essential drugs. And the question to Nerja, the WHO perspective, could this be related to the increased maternal mortality in these countries? That's from the chat.
Yeah, I don't know that I have the data for this, but I think uncontrolled epilepsy, for example, could be one of the contributors. So I think we mentioned right in the beginning, I think it was you, Eugene, who said that we need to balance the seizure control with the effect that these medicines have on the fetus. So I think having that balanced view, seeing what's best for the woman, with informed decision-making is the way to go ahead.
Thank you very much. That's important. And it's always quite important to have healthcare measures which we believe can influence mortality, which is the hardest outcome. So it is time to end, unfortunately, and I would love to have maybe a brief closing remark by you guys from the IBE perspective, and then Nerja from the WHO perspective. Is that okay? Just what are your take-home messages briefly?
Very briefly, the take-home message is that we want women to be able to make decisions about the management of any pregnancies. And to do that, they have to be well-informed, well-educated, and have access to good information. And we want to promote that as a joint initiative between the IBE, the ILAA, and WHO.
Great, thanks, Gus. You presented my first point about information, so I think that is absolutely essential. The second point is we have a great opportunity with MHGAP. We do disseminate MHGAP. It's been used in over 100 countries, translated in more than 20 languages. So that is an opportunity for us to also disseminate this information, to train healthcare providers in the information they need. And I'm talking about non-specialists. So remembering that we don't have enough specialists in most places of the world, how do we train and support non-specialists to be able to choose the right anti-seizure medicine and provide this? And finally, I think is the point about improving access to medicines beyond valproate. Unless we have that, we are not going to be able to change the needle on this. Thank you very much.
Thank you. Thank you so much for the words, and thank you so much for the active discussion and the presentations. I think I learned a lot, and I hope that our audience also got a great piece of information, which was fantastic. So thank you very much for doing that. So, and I want to thank especially the WHO, IBE, and all the ILAE speakers for having this joint educational webinar. And I may do some advertisement at the end, because there is at the European Epilepsy Congress in Rome in September a further learning program, which is on epilepsy and reproductive health, a parallel session, or a mini forum on epilepsy nursing care models in Europe. And as I mentioned, Europe includes also low-income countries, and some of the richest countries are outside of the European Union. So this is worthwhile to visit. And the other thing is our ILAE Academy. It's the eBrain session level 1 on pregnancy and epilepsy, and the level 2 case on anti-seizure medicine selection in childbearing women. So end of the advertisement, and thank you all for being here. It was a pleasure talking to you. I'm sorry that it ends now, but everything has an end. Thank you very much for being here. It was great.